The ALS Society of Quebec welcomes you to this conference on cannabis. I will be your moderator today for today's conference. We have the French and English version organized for today. I'd like to welcome Dr. Genge, who will be doing the English portion, and we'll have Dr. Massey join us afterwards for the French portion. If ever in the meantime, just to let you all know, so we'll be doing a bit more presentation of 30 minutes at the beginning, and we'll be taking questions afterwards. So please feel free to write in your questions in the chat box below, or we will give you the opportunity to share your thoughts afterwards more verbally. In the meantime, everyone's going to be muted so that we don't get interrupted. But if not, then I welcome Dr. Genge to begin the presentation, and welcome again, everyone.
Hi, everyone. Just give me a minute to set up my screen. You can tell me if it's working. Do you see my screen properly, Nadine?
Yes. Yes, perfect. Thank you.
So I will be talking to you all about marijuana, how it can be used in ALS, a little bit of the background, and how we approach it here at the clinic at the Neuro at McGill. Marijuana has been around longer than we have, as you all know. And I first started prescribing it not for ALS, but even before I started working in ALS, for patients with AIDS, way back in the 80s and early 90s. At that time, it was extremely controversial. We have come a long way since then. And my very first encounter with a panel involved the RCMP and the federal government and the local police and Dr. Mark Ware, who is a very well-known cannabis researcher way back in the 90s when we were arguing for its use, particularly for pain in patients who were suffering from AIDS. So what is cannabis all about? Let's see if I can get this to move. Just 1 second, because this is just technology. You never know with technology. So what is cannabis? It's a plant. Pretty simple. It's been used since the time before Christ in BC, originally grown in Asia, which I thought was interesting, but it contains two particular compounds that we believe are the two active compounds, although the plant itself contains other components that are considered not active substances, but are important nonetheless. But we look at both THC, which has some therapeutic effects, but is what gives the high for recreational cannabis users, and CBD, or cannabidiol, which has been very much the focus of most therapeutic interventions. And it does not cause the high, but can treat many different symptoms that we should be aware of. And then there are the other components which are considered less important, but may not be. So when you look at cannabis, most of what we talk about, we try to separate between those two active components, CBD and THC. The CBD component is, which is being used more and more now across the board. It's being used for things as different as epilepsy. It's used for pain. It is used for sleep. And it certainly appears to do a few things. It appears to cause drowsiness. So some people use it simply as a sleep aid, but it also appears to relieve spasms, improve appetite, relieve pain. It may have an anti-inflammatory effect, which is very important. It may have an antibacterial effect. We don't know. It certainly appears to be the key ingredient that decreases nausea. So marijuana and its derivatives have been used for a long time now for treatments of chemotherapy-induced nausea, and it certainly helps with anxiety. The THC component also appears to help both pain and appetite, but it is clearly the effect that, it is clearly the component that causes the various psychoactive properties. Prescription cannabinoids come in multiple different forms. And these have been approved over the last 20 years for various things during the period of time when medical marijuana was closely watched and controlled, and prior to the approval, is approval the right word? The decriminalization of marijuana. These were the medications that were being used fairly commonly. At least in my practice, I've completely shifted away from these sorts of sources or medications that are cannabinoid derivatives or derivatives of marijuana to the marijuana products itself. For a variety of reasons, I think that using the forms of marijuana that we can now get, particularly in oils and capsules that contain the oils, in my practice is the most common way I use the medication. So, but just to quickly tell everyone, dronabinol, nabilone, and these sprays, it was called Sativex, the spray, but it's also called nabiximols, so that's why we call it Sativex. These were all studied in clinical trials and were approved for various uses outside of ALS. Not, as you can see from this slide, nausea, vomiting, and anorexia, particularly related to AIDS, chemotherapy-induced nausea, and Sativex was approved for MS-related neuropathic pain and spasticity. So why do we use it in ALS? Well, in ALS, there are a number of symptoms that actually can have a huge effect, as you all know, on your quality of life and your ability to function with this disease, with this condition. And these symptoms, some of them are bulbar or affecting speech, swallowing, and general bulbar function. And some of these symptoms are more related to extremity symptoms. Overarching both is this sense of anxiety and insomnia that regardless of where your ALS starts, you can be affected by. And what we've seen is a very significant benefit to a lot of different symptoms. So I'll be talking about this again. But the symptoms that I believe marijuana, either predominantly CBD, or a combination of CBD and THC treats. So the symptoms that we're really targeting are pain, which can be from lack of movement, positioning. We get some entrapment pain. Certainly cramps can fall under pain. Spasticity itself, marijuana is one of the better treatments for spasticity in ALS. It generally helps people who are having trouble with their appetite. Salaria is the hypersalivation or the excess saliva. And there's evidence in our clinical practice, and Dr. O'Connell, who practices in New Brunswick, has seen the same thing, that it can help decrease excess saliva, which, as some of you know, can be really disturbing. We use other treatments as well, but it's one of the key treatments. Anxiety, particularly when it affects sleep, can be controlled. And some people find that it helps if they're becoming depressed. There have been studies, and I'll talk about a couple of them. And we have been working on a trial. It's for a couple of years now. Unfortunately, the industry sponsor withdrew this year, so we're looking at doing the trial with another group, but really important stuff. There have been publications. So for the patient community, it's important to know that it really helps us as clinicians in our prescribing of marijuana to that there have been actual studies using different forms of marijuana, and that the studies have shown the benefit. It helps support us if anyone ever questions the use of marijuana in patients. But one of the first things published in ALS was published way back in 2004. So that's 16 years ago. And they did a survey at the time in their clinic. And I think this one was an American survey because it was anonymous. And even in 2004, we were prescribing it under Health Canada approval in Canada and in the UK. And they reported a variety of improvements. Obviously, appetite. I think everyone would agree that appetite is a no-brainer. Appetite should improve. Depression was reported improved with marijuana. Neuropathic pain was again reported. Spasticity and the hypersalivation. Then a group did in 2012. They used a synthetic THC, which is a psychoactive part of marijuana, and they looked for improvement and tolerability of that. And then in 2010, there was another paper that looked at whether it helped cramps, but that paper, which we think may have just had the wrong combination, it didn't include the CBD, and we believe that the CBD oil is actually the most important part for many of these symptoms. And then finally, very recently, a very helpful study has come out. I believe this study is from Italy. Yeah, it's from Italy. And this study was done very much like we do all sorts of drug trials. They actually took a group of patients. In this case, they took 60 people with ALS and used the drug form, not the plant form that we get now with the oils, but they use Sativex. Now, what's interesting about Sativex, it's actually a drug that a treatment, it's a spray, but it's actually derived from plants. So it's not synthetic. It wasn't made in a chemistry lab. I've actually visited the plant in the United Kingdom, the UK, where they make Sativex, and it's they have these huge sort of greenhouses of marijuana plants that they use to create this spray, this drug, and they have to do lots of different things to make sure that the balance that they talk about, which is 1-to-1 THC to CBD, is what they're producing in every single spray. So it's taking a plant and really creating a drug, but not making it in a chemistry lab, but directly from the plant. So in this particular case, Sativex is actually in its most simplest form, it's organic because it actually is derived from the plant. And they looked at how people responded in terms of their spasticity, in terms of their pain, and in terms of how they felt. When you hear an expression that says global impression of change, that's really a one question scale that asks patients who have been a part of a trial how they felt on the drug. And this study, which came out of Italy, showed a clear, significant improvement in patients who were on the drug as opposed to placebo. So this really is one of the trials that's really precipitating our push, or confirming more than precipitating, it's confirming our use of marijuana in patients with ALS for certain symptoms. This one was published only 2 years ago, but it certainly supports what we've been doing here for years. So what do? We prescribe it as medical marijuana. We suggest that people go with the oil and swallow it either by itself or in applesauce, or one of my staff did a taste test and they decided that the best way to use the oil, if you're using the pure oil, is chocolate mousse. It masks the flavor the most. Or you get the capsules. We have used, I'll prescribe up to 1 gram a day, and I tend to prescribe CBD or a mix of CBD and THC during the day with CBD at night. And I ask people to titrate up. When I use the word titrate, I say start with 1 drop, then go to 2 if you're using the oils, rather than assume that you can handle a lot of the oil. Start slowly over a few days. And you can then find the best balance for you that helps the most with your various symptoms. We do get some help from a clinic. There's a couple of clinics in Montreal. One called Santé Cannabis, and there's at least one more that we send people to. If people are not comfortable just starting it themselves, the CBD oil alone, they can sit with experts in the use of marijuana, medical marijuana, who will help them design the balance. As I said, we are looking at a range where we use CBD only at night, and in certain patients we use THC, a small amount of THC with CBD during the day. We prescribe it for a year, but I definitely have current patients who've been on it for 4 or 5 years. Typically we use Spectrum Therapeutics, but there are several companies that produce reliable forms of marijuana. When I say reliable, what I'm meaning is that you get the same strength of CBD and THC in each bottle or in each set of capsules. That's the most important thing. You don't want to be using a different combination or a different strength of THC and CBD every month. You want to comfortably know what you're taking. There's a form we fill out so that everything is identified and it's not stressful, and the medication can be shipped directly to your home. At the time that one of my staff looked, about 40% of our patients take some form of marijuana. There are people who cannot take marijuana, and there is a very short list of people who cannot. There's a slightly longer list of people who will not. The people who cannot take marijuana are people who have had a previous experience when they were young and actually had significant side effects of the marijuana. So in general terms, what that means is they had a bad high when they were experimenting with marijuana when they were young. And those patients we actually are very careful with. If they report a bad trip or a bad high when they were young, we're somewhat reluctant to give it. The only other group that we have that is not prescribed is people who, for social reasons, do not want to try marijuana. But other than that, I have prescribed it for people anywhere from 18 to 92. I prescribed it to nuns. I have prescribed it for virtually anybody who is interested in trying to manage their symptoms effectively and improve their quality of life. There are specific regulations, and the registration for medical purposes is really done to protect the patients. There are some doctors who are very uncomfortable prescribing marijuana, and if they are not used to it, or they've not done it before, they are nervous that they will land on some list at Health Canada. But as I said, I've been prescribing it since the early 90s, and so far, whatever list I'm on doesn't seem to cause any problems. So I'm very comfortable doing that for people. You will receive a certificate, and it allows you to carry medical cannabis. And prior to the decriminalization of medical marijuana, it also allowed patients to grow their own, which some patients preferred. Certainly, the Cannabis Act in October 2018 has made all of that much easier. Symptom management for ALS, a pilot study. This is the plan that we have, that we hope to eventually do in some format. And what we would like to do is to compare predominantly THC to predominantly CBD to a 1-to-1 ratio. And it will be, as I mentioned, it will be given, the oil will be given either as a liquid in something like chocolate mousse, or it will be given through the gastrostomy. This is for the patients who've never sort of been involved in a clinical trial. This is the way we kind of do these things. We make it, for this particular trial, we'll make a sequence of different orders in which you'll try the different products. And based on your symptoms during each 5-day period, we'll be able to see which of the combinations works best for which symptoms. So there'll be lots of questionnaires, and those questionnaires will be directed towards spasticity, pain, cramps, appetite, impaired sleep, anxiety, and hypersalivation or sialorrhea. We'll make sure that all the other medications are stable, and we'll of course make sure that no one is pregnant and going into the study. I think that's the most important thing. We'll be looking at a quality of life scale. So again, if you've never been in a clinical trial, one of the things we do, clinical trials are not very onerous, and people feel very much supported when they join in a clinical trial. But we do have lots of questionnaires, and the questionnaires don't take that long, but they're important for us to be able to prove that a drug is good for the patient. And in this case, what we're looking for is that people feel better. And we want to get more specific than that. We want to be able to say that these symptoms improve, because this is what we believe based on all of our clinical experience that marijuana will help with. We'll check some other things. These are the kind of tests that we do. There are pain scales, there are some ALS scales, but really it's all about proving what we see. We always look at safety in a clinical trial, and we always look at how well tolerated a trial is. And really that's the key of what we do when we're looking in a clinical trial. What I can say right now is, based on all of our experience, all of my experience over almost 30 years, pain can absolutely be improved with forms of medical marijuana. Depending on the severity of the pain, medical marijuana can be combined with other forms of pain medication, but your doctor and you have to be very aware of everything you're taking. And the ratio must include significant amount of CBD for pain. CBD is also extremely important for the sleep component and the spasticity component. The THC may be an important element when you have a loss of appetite, and the THC component can really help you in determining and improving your appetite, gaining weight, because most of you may know that the most important thing that a patient can control in this disease that feels very much out of your control is your weight. And we know that the better you are at keeping weight on, the better everything else can be. It seems to help support your strength so that you don't lose strength faster than you need to. And it certainly, the weight supports a lot of different things. The other things, as I mentioned already, and I'm going to reiterate, it can help if you find that you're getting anxious, and it certainly can help your increased saliva. So we certainly choose to give patients this medication, and the medication and the balance of the two components is a little bit of trial and error, but the main thing I want to stress is the CBD is really important. I've had a couple patients actually help me in determining when you should take what during the day. And again, I'm going to reiterate that starting very low is probably a really good idea. If you choose to get your marijuana from a dispensary, something to remind everybody is the marijuana in the dispensaries is not the marijuana that you smoked when you were 19 years old. And it's a much purer product now, and that's how we talk about it. We talk about it as a product. So to start low is really important. Now, there are patients, particularly those who have trouble swallowing, that actually prefer to smoke the marijuana, to use or to inhale it through another device. And that's totally okay. You just need to be careful that you don't start with too much. And I'm saying it about 5 different ways in order for you to understand that this is not trivial, that if you start low and increase carefully, you're much more likely to get a positive benefit. The other thing, and this came up this week with a patient who's noticed that the marijuana that I prescribed is really helping her pain and spasticity, and a lot of her pain is coming from her spasticity. And so what we've done is, rather than really up the dose that she takes twice a day, we've spread it out, and we've kept on the lower dose, but she now takes her marijuana 4 times a day. And that seems to even out the spasticity and the pain, and now will just gradually increase. So just the step after starting the medication may be to take it slightly more frequently rather than take a stronger and stronger dose. Everyone's a little different, so I'm not saying that it's not like prescribing a blood pressure medication where we can monitor your blood pressure, or insulin for diabetes where we can monitor your blood sugar. This is really to control these symptoms so that we try to get the best possible combination for you. And always remember that the THC does give the high, so we have to be careful about the THC. And there is an issue with driving if you're using anything that includes the THC. The last few minutes, and I'm going to take 5 minutes on this, Nadine, is to tell you a little bit of information. I think if you dig deep on the internet, you can find it. But there is some evidence out there that the marijuana actually may have a bit of a protective effect in addition to its treatment effect. And by that, I mean there is some work that's been done that suggests that marijuana also can slow down the progression of the disease. So this little slide talks about the endocannabinoid system as a therapeutic target. So there are people working on making drugs that actually target either one of these receptors, CB1 or CB2. They're trying to mimic or maximize the targeting these receptors to try to decrease any inflammation caused by the immune system, and thereby actually slowing down the disease. So this is slightly different than treating a symptom. This is actually trying to treat the disease itself. So there are people out there using what we know about marijuana and ALS and trying to design drugs that would treat ALS by targeting these marijuana type receptors. It's called the endocannabinoid system that's being targeted. And we talk about two different receptors, CB1 and CB2. Just give me a sec. I'm doing one of these technology things again. So the disease modifying properties, so that means the treatment of the ALS itself and not the symptoms, are coming from some scientific evidence that shows some models of ALS in animals seem to do better when we treat them with drugs that target these receptors. And it looks like it's drugs that turn on the receptors rather than turning them off. And it may work directly in the nervous system, or it may work through the immune system and may, in fact, decrease inflammation in a variety of ways by decreasing things that encourage inflammation and increasing parts of the immune system that naturally decrease inflammation. So in that way, it may be neuroprotective. And so it may be that many years from now, because it will take a while, none of the current clinical trials are using medical marijuana for or targets of the cannabinoid system to treat ALS. But it may be that years from now, we'll see a difference between those patients using medical marijuana to treat their symptoms and those that do not, in terms of how quickly their disease progresses. Sometimes, and all the time, we wish we had the answers a lot faster, but at this point, we're just able to share what we observe. But certainly, if I have one concluding comment before the questions, it's feel comfortable in asking. If you don't come to our clinic and go to another clinic, that's not a problem. Discuss with your neurologist exactly how you can try medical marijuana or marijuana through the oils to control some of your symptoms, because it certainly can make a big difference in the symptoms I listed earlier: pain, sleep, appetite, spasticity, cramps, and hypersalivation. So with that, I want to thank you for listening, and I'm going to have Nadine ask me questions that are in the chat box.
Yes, thank you very much, Dr. Genge, for your time and for your presentation. Very interesting. I will take about maybe more or less 10 minutes, depending on how many questions we had. I know we've had one coming from the chat box, if I'm not mistaken, regarding cannabis oil. I think it's been mentioned a little bit briefly during our presentation, but this person is wondering if cannabis oil can be administered through a feeding tube, and if so or not, what do you normally prescribe for people on feeding tube?
So the cannabis oil is ideal for giving pain medication through a feeding tube. It is sometimes hard to get it to mix in, but people actually sometimes put it in their feeds or in something like Entor, whatever liquid they're giving through the feeding tube, and it goes in directly. So it's actually ideal as a pain, spasticity, anxiety therapy for patients with a feeding tube. Again, even with a feeding tube and oil, you should start low. So, because you don't know your own reaction until you've tried it. Don't be shy to increase it if you're not noticing a benefit, but you do start low. Don't go in and give yourself like 10 drops your first time. Even if you tried marijuana when you were 21, you should start low and slowly increase.
Great. Thank you for the advice. I want to invite people to keep on asking questions in the chat box. If anyone else has questions, please feel free to do so. If not, you guys are also welcome to take off the mute device if you want to express it verbally.
So while I'm waiting for questions, I think there are a couple of other things to know. And it's something that I have used in the past. That is an incorrect statement. Patients have used in the past. And that is using the oils or the actual plant in food and taking it through eating a cookie or a brownie or something like that. Some people have had tremendous success with taking it that way instead of taking it like a medication. There are even recipes on the internet as to how to do that. I don't have them. You've got to go on the internet. One of my staff found them one time, so they're there. The key for me is to make sure that you're not just taking a pure THC product, because the CBD seems to be better for certain symptoms, and some of these symptoms are the most distressing symptoms. So make sure that whatever you're taking includes CBD, and add in the THC just as an additional benefit. That would be my advice. Dr. Massey may have other advice. You'll hear it in French, so I won't hear it, but that would be my advice. Make sure there's CBD in the product, and just be careful about how much THC is part of the product because of this psychoactive component. Okay?
Okay. We have one other question. Okay, we're receiving several. One person says that their mother is on one of your clinical trials, more particularly the oral form of edaravone, and can she try cannabis oil while being on this trial?
Yeah. Yes.
Okay.
She just has to let us know.
Okay.
That's the key with marijuana, is to not hide it. First of all, we're very open, and I actually obviously consider it a drug. I consider it a medication that's derived from a plant that can be fairly effective, very effective for certain symptoms. It doesn't work for all patients for every symptom. So like any other drug, there's no guarantee. But the most important thing for us when you're being followed in clinic or in a clinical trial is we know what you're taking. We're not judging, we just need to know, because there may be things that you don't realize can interact, and we may be able to advise you that one of the other things, the non-prescribed things, are interacting with some of your drugs. So that's my most important piece on the marijuana.
Okay. Thank
and
you.
Make sure your housekeeper does not eat your brownies, because I have had that years ago. Someone had perfect container of marijuana brownies in the fridge, forgot to tell the housekeeper, and came home to a very high housekeeper. So just make sure that if you do the baked goods, everyone around you knows.
That's good to know. We'll keep in mind. We also have, it's almost the same question. Somebody else is asking, what if the ALS patient also has Alzheimer's? Can they still take?
So that's actually a super good question. Okay, that's a great question. If they have Alzheimer's, I would expect that the THC would be the problem. So certainly there are trials now. There are clinical trials using CBD in Alzheimer's. There are clinical trials using CBD with a small amount of THC in Alzheimer's to treat certain symptoms. but I would just be cautious about the THC component of the marijuana. CBD, marijuana is being used for various things like head injury. It is being used for epilepsy, as I said, including in children. It is starting to be used in anxiety disorders as a treatment, not as something people take on the side, but physician-approved treatments. Okay, so all of this to say, I think that it can be used. It just needs to be done a little bit more carefully if someone has something like Alzheimer's or one of the other dementias, because maybe some of you don't know, but dementia doesn't mean Alzheimer's. There are people who have kinds of dementia, but the dementia is different than Alzheimer's. So they may even have a good memory, but their personality has changed completely, or they're seeing or hearing things. And those patients in particular don't do very well with the THC often. Okay?
Okay. Okay. Thank you. We'll take maybe one last question. It's more of a general question. The person is just asking how can they be on the cannabis trial or any of the trials that are going on at the moment?
So any trial that they're going on, they just have to come to clinic. We will see anybody who's interested in a clinical trial, even if you're being followed somewhere else. It's not a problem for us. For the cannabis trial, we will be probably doing it with a different group. And as soon as it's approved, we'll let everybody know that comes to clinics, and we'll let ALS Quebec know so that anyone who's interested in doing it that way, they certainly can join. Okay?
Okay.
So for those who, somebody also asked, Radicava and Edaravone are the same thing, and you can take CBD while you're on Radicava, and you can take CBD while you're on Riluzole, and you can take CBD when you're on Quinadex. There's no reason that you can't take it with any of those. The only thing you have to make sure your doctor knows about is if you're on any strong sleeping pills. And we would need to know that because it may change the sleeping pills that you're on. Okay? With that, Nadine, I'm going to turn it over to you, and you can introduce Dr. Massey.
Yes, thank you so much, Dr. Genge, for your time. And people are sharing through the chat box that it was very informative. So thank you so much for your time, and wishing you a lovely day.
Thank you. Take care now.
You too.
Bye.